So you asked me to give a talk about new bone formation and whether or not this is or it is not coupled with inflammation and in spondyloarthritis. And we know that the topic is of interest because inflammation is the main reason, okay, for rheumatic diseases, but also for spondyloarthritis, especially because we see inflammation being in the bone. And thereafter, something new grows from the bone within the inflammation, something new grows. And the question is, how can that happen? We have said this or discussed a lot about whether or not this would be enthesitic inflammation. We've discussed a lot whether or not it is something different. In the meantime, I believe we come back to the beginning that we don't really know much, or at least we start now getting another route. Obviously, it's not only an enthesitic inflammation, it's also the bone itself that sends out the message to get new bone built up. So I will try to show you a couple of old and a couple of new things of how this works. Now, I start with the end. And the end is, why do we believe that this is of importance to stop this new bone formation? Yeah. Well, maybe as it might be, let's say, a fibrotic situation in the lung in rheumatoid arthritis, where we know that up to a certain time, a certain point, we can still take care of that, and the patients will not really have huge issues. The same is also for new bone formation in spondyloarthritis. Unfortunately, I cannot show on my screen right now because I've seen that the pointer is not working on my end, but I will try to explain that. And what you see here is the EMSAS, which is the score that we use for radiographic damage. And on the other side, on the left side, on the y-axis, the BAS-Phi, the functional index, where patients cannot move properly. And we see that although radiographic damage may worsen, the function is not worsening so much. But from one time point and on, the function really worsens a lot. This means long time, nothing happens. And we want this to go, we want stopping this going on because from one point and on, we will not be able to control it, and therefore the functional disability will come. So it is important to stop radiographic progression or damage in the very beginning. Can we do that? That's a busy slide. Again, I cannot really guide you through with a pointer, but maybe the most important thing is on the left and low part of the slide. You see that the BAS die after one biologic, whatever that is. Now I took the adalimumab data here, but you can take everything. The BAS die, the disease activity index, it improves, but similarly, also the BAS-Phi, the functional index improves as well over 5 years. This means that indeed, and by the way, it improves after 12 weeks and after 5 years. You see that on the right side of the slide. So this means if we improve disease activity, we will also be able to improve function. Okay, the things that I showed you before. Here, X-ray damage has not yet been incorporated. So one thing to make it clinically relevant, the topic that we're talking about today, is to improve disease activity, but also stop radiographic progression going on in order to maintain and or maybe even improve function. And why is that still important? We also know that mobility in general, not only function is how I do the things, like how can I take something from a high shelf. But mobility is what I measure as a physician. These are data for mobility. We've seen that inhibition of radiographic damage is also important for mobility, since if we check the MRI, this means the inflammation, and the X-ray scores in a population of patients with ankylosing spondylitis, and we try to separate them and correlate them with mobility indexes, or the mobility index, we will see that in the early phases of the disease, in the first 3 years, mobility restriction, this means the patients really cannot, the chest expansion is, for example, limited. This mobility restriction is significantly associated with inflammation in the beginning. And after 3 or 4 years, then the X-ray comes in. This means, again, the inhibition of radiographic damage for the topic of today's presentation, the coupling with inflammation, is important because if we stop inflammation in the beginning, then we also improve mobility. If we do not stop inflammation in the beginning, then the X-rays will come in and then we cannot change that anymore. So what we take out of this slide so far is that radiographic damage and progression are important because we can explain the clinical symptoms of the patients beyond disease activity. And if we start in the beginning, we treat inflammation. If we let radiographic damage come in, then functional impairment will come in and we cannot stop it anymore. That's the essence of this short introduction. Now, I mentioned the EMSAS pretty many times already. I would just like to remind you that this EMSAS is a score that we are using now for many years. It's not perfect. I will show you also the limitations at the end. But what it's doing is that it is scoring the X-rays of the cervical and the lumbar spine, the anterior part here for the cervical spine, and it's especially scoring the syndesmophytes and the ankyloses. This means we have a score that mainly or heavily is associated, the higher it gets, with new bone formation. It ranges between 0 and 72, so the range is relatively wide. But even a score of 1 or a worsening of 1 is important, or of a 2, because this might mean a new syndesmophyte. And we have analyzed this kind of relationship over the time in patients with ankylosing spondylitis already many years ago, and we've seen that if you take a population with ankylosing spondylitis patients and you follow them up over many years, then you will see that they really constantly, all of them, constantly they worsen. But if you look at it more, this is a linear progression. If you look at it in more detail, you will see that every fourth of them contributes to that linear progression, specifically with a very fast progression within a very heavy progression within a very short period of time. This means the linear progression is not so important. Important is to understand who is and who is not at high risk to develop progression, because these patients need even more and even more urgent treatment. That's something we clinically need to take into account. Now, what are the reasons to have progressions? Who are the patients of high risk? We know from this one study from Germany, I know I take it because I know it a little bit better, but also from other studies all over the world, CRP is the most important biomarker to predict radiographic progression. And it's not so much how high the CRP is, it is any high CRP. If you have a patient with high CRP, here the cutoff was 6 milligrams per liter. If you have a patient with high CRP beyond your cutoff or above your cutoff, then there is significantly higher risk to develop radiographic damage after 2 years only, as compared to patients who have normal CRP. So positive CRP is a risk for progression. Another biomarker which is important that we know already that is important is DKOP1, DKK1. Now, this is not a biomarker that we are examining every day in our daily practice, and these are small samples. But in many studies, we've seen that DKOP1 is associated with osteoblastic activity. And how is it associated with osteoblastic activity? If it is low, then osteoblasts go up. So it is, in fact, if it is there, it is protective. If it's missing, then more new bone formation go up. So low DKOP, more progression. Another reason to have new bone formation, so CRP, DKOP1 we discussed. Another reason is, and this is in fact what I mentioned before, the late diagnosis. What do I mean by that? It means that if you take two cohorts which are similar in the number, so we can have equalized them by the number of patients who are included. And you see in the one cohort, we have no syndesmophytes, so they are at least considered being diagnosed a bit earlier. And in the other cohort, we have syndesmophytes, so they are diagnosed later. And if we look what happens 2 years later, we see that significantly more patients develop even more syndesmophytes if they have syndesmophytes in the beginning. So the time point of diagnosis or the occurrence of at least one syndesmophyte is significantly associated with more syndesmophytes later. And this has been shown first time in that study that I showed you here from our data. And actually every study since then has confirmed that. So there's many, I want to say there's many data to confirm this finding. And here are the newest information that we have received from Korea, where they checked now the combination CRP and the syndesmophytes at baseline. And they have seen that the combination is even worse. On the right side, those patients with high CRP over time and with baseline syndesmophytes. On the left side, those patients with no CRP and no baseline syndesmophytes. And you see the big differences, right? So if you have a combination, it's even worse. And each of those factors contribute alone also to new bone formation. Now, these are the most important factors for new bone formation. And now we come to the question on whether or not inflammation is related to that. CRP is inflammation, but also MRI inflammation. I will come to that soon. One thing that we also need to take into account, of course, is whether or not we are able to, intervene and improve this development with our treatments. And I would like to remind you what we have in our treatment algorithm is non-steroidals and biologic DMARDs, TNF blockers and IL-17 inhibitors. And we also have JAK inhibitors, but the data so far are not there to talk about it much. So NSAIDs and biologic DMARDs, this is what we are relying on for treating patients clinically. You remember the BAS study, but also in terms of inflammation. Starting with the NSAIDs. We know that if we give NSAIDs continuously, this means every day, as compared to on demand, this means whenever the patient needs it, then the continuous treatment, I will try to move my mouse here, you see it's very slow. This is the continuous treatment. Lesser patients progress radiographically after 2 years, as compared to the patients who get it on the drug, the NSAIDs on demand. This means even if the cumulative dose is the same, continuous suppression of inflammatory activity by NSAIDs is better as compared to, well, every now and then. Of course, we cannot compare this with biologics, but at least continuous treatment is better. And we've seen that if we now take that into, let's say, more granularly, into more details, this group here of the patients in blue, they benefit the most as compared to the ones in red. This means less progression as compared to more progression if the patients who get the drugs, the NSAIDs continuously, also have high CRP. And this difference is not there in the comparison if the CRP is normal. So what I keep out of this message is that NSAIDs help for radiographic progression, but only if you take them over 2 years continuously and if CRP is continuously high. One thing is that it confirms CRP and inflammation is coupled with new bone formation, and if I decrease inflammation in general, systemic inflammation of NSAIDs, I have a benefit. But in fact, what we can say is that this is not a normal situation. Nobody nowadays would keep a patient 2 years long continuously on CRP, on NSAIDs, and with continuously high CRP levels. These are historical data, but they show us that NSAIDs may help, but they are not, it's not modern anymore. There has been also, by the way, this NSAID here, this historical study was done with COX-2 inhibitors. There has been a study from Germany where we tried it with diclofenac over 2 years. And you see continuous versus on demand, there was no difference. This means for the non-COX inhibitors, this doesn't really seem to be the case that they help much. The COX-IPs seem to be a bit better. And well, this is the only data we have which are reliable for radiographic progression for NSAIDs. We have many more data for biologic DMARDs, obviously, because there is also a pharmaceutical interest behind that, but because I also believe that they make more sense for the decrease, for the improvement of inflammation. Now, it might get a little bit complicated. I will try to to explain it step by step. What is the effect of biologics here with a TNF blocker? But I would say it's for all biologics. What is the effect of biologics on all the parameters that I mentioned, starting with CRP and DCOP1? Here is a very nice study that has compared ankylosing spondylitis and rheumatoid arthritis. And what they did was to see before and after TNF blockade for the BASTI and for the DAS28. Obviously, and as expected, these are single patients. Disease activity improved, not in everyone, but in the vast majority of patients. Now, CRP also improved. Of course, in the EAS patients, not many will have high CRP, but those who have high CRP, they improve. Okay, and the same is for rheumatoid arthritis. CRP goes down. Already this result would tell us that by giving a biologic, since we decrease CRP, we have higher chances to positively affect radiographic progression. And what they've shown is also that the DCOP1 levels have changed. In ankylosing spondylitis, they have increased. This means obviously protective. Remember, low DCOP, more progression, high DCOP, less progression. And in rheumatoid arthritis, DCOP1 decreased. We know that, for example, erosions, they get filled up. So overall, this data already will tell us that giving a biologic, in that case a TNF blocker, but again, it doesn't really matter, giving a biologic, we would have a protective effect on radiographic progression, which I will show you is also true, but it takes some time and there is some things to think about when we discuss that. By the way, the difference between the diagnosis and why a biologic acts like that is that it seems that in ankylosing spondylitis, this DCOP molecule seems to be different and dysfunctional as compared to rheumatoid arthritis. So it's a more or less a molecular information that I give you here. By the way, we've also seen, and this now takes not only a short period of time, but also a long period of time into account. I go back to CRP. We've seen that, again, if you at baseline have high CRP levels, this is in black, then over 4 years, you will have more progression. I mentioned that. But if you look at the half of the time after 2 years, those patients who normalized their CRP at year 2, they had significantly less progression as after 2 years later, at year 4, as compared to those patients who did not normalize their CRP after 2 years. So it's not only that we normalize it, we want to continue having low CRP because this also positively affects radiographic progression. Now, how does this all work, both for NSAIDs and also for biologics? For NSAIDs, it's a little bit difficult to believe that they really have an impact on radiographic progression. And the data that we've seen before, there were always questions. But if you look at the data that I show you here, for example, if we have a prostaglandin increase in those patients, and especially in the COX-2 inhibitors, we know that this might be even more severely affected. If we then say that prostaglandin secretion does lead to lower DCOP1 levels, but also sclerostin levels go up, then stopping or positively affecting this prostaglandin synthesis, then this will also obviously, and this is now very roughly explained, also positively will affect the DCOP1 molecule to be increased even in ankylosing spondylitis. So this is one very, again, because of the time, I'm not going into all details of what beta-catenin does and so on, but overall this might explain why the DCOP1 why the radiographic progression may also be affected positively by COX-2 inhibitors. Now, going into other parameters and now going into more, let's say, morphotypic findings on MRI, and going back to the question on whether or not newborn formation is coupled or not coupled to inflammation, the way we assess it by MRI. I'm showing you here this data on MRI, where we have seen that, for example, after 3 months, or here after 6 months, after 12 months, or even after 6 weeks, we have a significant decrease of inflammation. So by a biologic, either TNF blockers or IL-17 inhibitors. This all means that obviously also on the morphological level, on the phenotypical level, we influence, and not only on CRP, we influence inflammation positively in terms of decreasing it, and hopefully also decreasing or even stopping radiographic progression from that perspective. And this was actually a relatively easy thought, or an easy thought we had many years ago. Things have changed. I will show you a little bit what have changed. We thought in the very beginning, and these are older data, 2008, 9, or 11, they were published. And by the way, they all showed the same result. If we have inflammation, 2 years later, we have newborn formation. And this is an odds ratio which was significant. And in all the 3 studies that I show you here, the same data occurred. Odds ratio around 3. So newborn formation is associated with previous inflammation. That's something that we believed, and therefore we believed that stopping inflammation will stop newborn formation. However, we understood a couple of years later that if we have inflammation only, this is not directly associated with newborn formation. Here we have this, the following experiment. We have T sequences on the MRI which show inflammation, and we have T1 sequences on the MRI which show post-inflammatory lesions, fat degeneration. And we have the following combinations: inflammation without fat, no inflammation here, but fat. Type 3, or the third combination, is inflammation and fat together, and type 4 was nothing, no inflammation, no fat. And we took X-rays which had no syndesmophytes, and we checked if they developed syndesmophytes later on. And we tried to analyze or understand, after 5 years, which of these inflammatory or post-inflammatory lesions at MRI are significantly associated with syndesmophyte development 5 years later. And we had an examination in between. And what we found was that the only reason to get newborn formation, now independent of the biomarkers, the only reason to get syndesmophytes is if you have fat development. Either you have it in the beginning, here, or you develop it over time. So inflammation goes away. If you have new fat, then you develop new syndesmophytes with a significantly associated, and you remember, it's the same odds ratio, but it's a different cohort with the same significant odds ratio. And if you have inflammation and you do not develop fat development minus, then the odds ratio is below 1. So actually there is no risk. So the relative risk is below 1. So there's no risk. So overall, it is not the inflammation, it is the post-inflammatory lesions. So directly, yes, newborn formation is coupled with inflammation, but at some point it gets uncoupled, which to me means not so much uncoupled, but actually out of control. And therefore, we need to stop this fat development. Now, we try to go into more details and understand why fat development is associated with newborn formation. And we did those, this is just one snapshot, a PET MRI study. We did a PET and we fused it with an MRI examination. Excuse me. And we found that this PET tracer, which was a specific tracer for osteoblastic activity, it was significantly associated with fat. This means this fat shows osteoblastic activity, and these osteoblasts lead to newborn formation. And therefore the question is, how can fat, the post-inflammatory lesion, develop osteoblasts? What is wrong with this fat? We then went on and said, okay, if fat is leading to newborn formation, can we analyze the fat in a biopsy study? And you see here, the question was, what constitutes fat metaplasia? And why is that happening? And this is now an enlargement of a biopsy. This is the syndesmophyte here. This is one zoom in picture of an area where you have fat and you have inflammation. So you remember coupling or uncoupling. And we were able to find out that in those areas which have fat, if we do the appropriate staining and compare it to the inflamed areas, we will find significantly more osteoblasts in the fat area. And interestingly, zero osteoclasts, which means fat, for whatever reason, it kills the osteoclasts. And the osteoblasts overreact and build a new bone. And there where we have fat, this is different. This is exactly the opposite. Maybe we have more osteoclastic activity because of the local osteoporotic activity. We know that where there is inflammation, we have osteoclasts. But if this inflammation remains untreated and gets uncoupled, then it will develop fat. And this fat will kill the osteoclasts, and therefore the osteoblasts go up. So it is a homeostasis which is disturbed, and therefore we need to treat. I come back to what I said at the beginning. We need to treat early in order to improve the local osteoporosis, we know that, and not allow this fat to come up. This is the concept that currently is internationally, let's say, accepted. Now, how can we intervene with drugs, with treatment? I mentioned the treatment algorithm before. Well, we know that in the older studies, when we gave the TNF blockers, independent of which TNF blocker we gave, there was still progression. When the bar goes up, there is progression in the EMSAs. And this progression was not significantly different to the historical cohort. This means after 2 years, we were not able to inhibit radiographic progression, although actually what I showed you before would have assumed that. Well, there's no newer data that have shown that after the first 2 years, there is progression. And in the next 2 years, there is less progression. So these are the first 2 years of treatment. These are the second 2 years. So this means the longer we treat, the lesser the progression will be. Obviously, meaning that it just takes more time to stop radiographic progression, especially if you have fat. This fat will work, continue working, and will build progression, but the inflamed areas will not build that. And when you look at the non-radiographic patients, the very early patients, where we really treat as early as possible, then there is actually zero progression. So either we treat very early, where the inflammation is coupled to newborn formation and we stop newborn formation, or we treat late, and there this uncoupling has already occurred, and the longer we treat, the better it is, but it takes time. This has also been shown in other studies. Here you see these are data from the Netherlands. They've shown that these are the first 4 years, the next 2 years, the next 2 years, over 8 years. In the first 2 years, and in the, just take this one, for example, in the second 2 years, radiographic progression was going on. Here you see then, when they checked for the first 2, the second 2, and the third 2 years, in the third 2-year interval, less radiographic progression happened. And here is the fourth 2-year interval, even lesser progression happened. So the longer they follow the patients up, the lesser the progression will be, especially when they have established disease and long-term data. Now, there have been also other studies in the newer literature with IL-17 inhibitors. All the data that I showed you before were with TNF blockers, where after 2 years, radiographic progression was lesser. Now, is this 0.3 really lesser than 0.9 with TNF blockers? I cannot tell you. There was no control group here either. But it might be that this is the case. And well, I'm always looking at the time. I don't want to make it too complicated. I would just like to tell you that, yes, it seems to be that either with the TNF, with the mean EMSAs, or with the so-called cumulative probability plot will see lesser progression. This means if you, as compared to the other studies, the patients who progress are, let's say, less than 20% of them progress, especially with secukinumab or with IL-17 inhibitors. But some of them will also improve, which cannot happen. Without, again, wanting to make it too complicated now, I just want to say that this mean progression rates that we are showing is always a little bit of a challenge, because the patients who progress may also be, who improve, may also come into the overall analysis. This is something we also see with TNF blockers, where some patients may have a background noise. This means improvement as well. I know that it might be a little bit too complicated if somebody is not really able to read all these cumulative probability plots. The main thing to bring this up here, and I understand that if I cannot show so well, it might get a little bit complicated, but in order to explain it, I just want to say that these measurements that we are doing are not always comparable with each other if you don't have a head-to-head trial. And therefore, the final result, and this is what you should take as a message out of this presentation, out of this part of the presentation, the final result on whether a TNF blocker or an IL-17 inhibitor is better cannot still be given. We need a head-to-head trial, and we are actually running a head-to-head trial right now. Just don't look at the MSAS units only. Take as a message, radiographic damage is being positively influenced. If the one or the other drug is better, we cannot answer at the moment. One thing that I would like, nevertheless, to have mentioned is that there is positive data with IL-17 inhibitors from rats, where they did inject the appropriate vendors in the rat to induce arthritis, which would lead to new bone formation. You see that here. And then when they treated with IL-17 inhibition, then the new bone formation did not really happen, or it happened only very minorly. You see here, this is periosteal ossification. If you treat the rats, if you don't treat the rats, you have a much more periosteal ossification. So this is actually even more data to support the fact that biologic treatment, as I mentioned in the beginning, is leading to the wished result. And the other thing that I bring this back, I would like to mention is again that we need to understand exactly what we're doing with all the biomarkers that we're having in front of us. I remind you the slide that I showed you before with the DKK1. This is not only, excuse me, this is not only in ankylosing spondylitis. This has, and with TNF blockers, this has also been shown in psoriatic arthritis with an IL-17 inhibitor. You see here, giving the IL-17 inhibitor DCOF1 increases. This means this is, I believe, a biologic effect, not so much a TNF blocker effect. And we expect to see really very positive results overall with our biologic treatment here. One thing that I would also like to mention is that, you know, this biomarker thing is not AES specific. It's not only for ankylosing spondylitis. We've seen that also in DISH. So DISH, which is also associated with new bone formation, is also associated with low DCOF levels. It seems to be that DCOF1 is a biomarker that is always associated with new bone formation, as compared to healthy controls. Healthy controls did not have, they had a higher distribution of DCOF1, and they had higher, significantly higher levels as compared to this, which had low levels of DCOF1. Unfortunately, we cannot correlate CRP with DCOF. This means the patient with high CRP does not necessarily have low DCOF level, or vice versa. Therefore, there's also patients with low CRP who show new bone formation. That's something we see. So it's a, let's say, it's a holistic approach that we should look at it here, and just remember that there's more than CRP as a biomarker to discuss in this concept. One thing that I am very, let's say, curious about is to see whether or not the one or the other biologic may influence also positively fatty lesions. I mentioned the role of fatty lesions in the new bone formation, and we've published some years ago that at least with secukinumab we have this data that treating with secukinumab decreases inflammatory activity, but also maintains fat lesions at the same level. We know that there is other data with other biologics where fatty lesions increase. We have not seen that with secukinumab so far. So there might be a little bit of a hint that secukinumab or IL-17 inhibition may be positive for the development of newborn formation. But again, we need the head-to-head trial, and I guess we will get the data from that trial, TNF blockade versus IL-17 blockade, at the end of this year. I will skip that. And I will just like to remind you that indeed in the long term, we've shown that biologic treatment has lesser radiographic progression as compared to non-biologic treatment, which has newborn formation or more radiographic progression. So overall, this is to confirm long-term treatment helps, and we need to keep the patients as long as it gets on the biologic treatment to also make them benefit from the radiographic progression. These are just other data to show that not only the long-term treatment, but the clinical effect is also important. So we've seen that if you reach ASDAS remission, less patients will progress. If you see that ASDAS remission is not reached, then more patients will progress. So it is indeed that the clinical effect on disease activity is influencing systemic disease activity, which again leads to lesser progression. Also, I'm just looking at the time. There's many different ways to look at it. I will skip that also. It's just to say that continuous treatment, even over 18 years, this is really key because it really leads to lesser progression overall. Now, one last thing I would like to mention here before I close is that there is also the question on whether combining biologics with NSAIDs may even lead to lesser progression. And the data that I show you here are not fully published yet. They are taken from the US registry. What they did was to compare the patients who had no biologic and those who did have biologic. And then they gave them NSAIDs, even high dose or no dose or no NSAIDs. And they find that if you combine TNF blockers or a biologic and high dose of NSAIDs, then you have lower chance to progress. If you have a TNF blocker and no NSAIDs, then the chance to progress is higher. But it is even higher if you get NSAIDs with no biologic. This means NSAIDs only are not so good as the combination, and biologic only is better than NSAID only, but also not so good as a combination. This means combination may be better. However, my opinion is a little bit different. My opinion is that, in fact, what we want to have is this here, somewhere in the middle. Why? Because this would mean also a good clinical effect. If I have a patient on a biologic who does not need any NSAID or just a little bit of an NSAID, I buy this difference by the good clinical effect. If I have a patient on a biologic who also needs high dose of NSAIDs, then I believe it's time to change the biologic rather than keeping the NSAID dose high. And the same here is with this one. If I have a patient with high dose of NSAID and with no biologic, then it's better to give the biologic and decrease the NSAIDs. So this means we still are somewhere in between. Otherwise, we would need to change the treatment. I wouldn't give, necessarily high dose of NSAIDs the whole time. I would rather go to low disease activity, because we've seen that continuously low disease activity means lesser radiographic progression. That's radiographic progression here. Continuous low disease activity leads over 12 years, leads to lesser radiographic progression. High disease activity, whatever the treatment is, leads to more radiographic progression. So overall, we can keep from this presentation, there is coupling and there is uncoupling from inflammation. We need to stop inflammation early, keep patients as long as possible on a low disease activity, then they benefit the best from radiographic progression and also for clinically. And if we don't do that, then obviously it's time to change the treatment. Last thing, problems with assessing radiographic damage. I mentioned the X-ray, the EMSAS. You remember, we only assess the cervical spine and the lumbar spine. We miss the thoracic spine. So that's something that we need to take into account. All the data I've shown you with the EMSAS, they missed half of the spine. One other thing that is that EMSAS is not assessing the posterior elements. There might also be syndesmophytes. And also importantly, it's not assessing the facet joints. So the MSAS in that case would be 0, because in the front part there is no syndesmophytes, but the patient still cannot move because the facet joints are fused. So these patients will also be missed by their scoring, Therefore, we also need to, always look at the data from both sides, and we still have to admit we don't know everything about this topic. Thank you.